Great. So just formally welcome everyone to April 29th Grand Rounds. And this is going to be a CPC, so always one of my favorites. Just a little bit of an introduction. So Dr. Catherine Hess has really been the mastermind of this, and she's one of our fantastic chief residents. For those of you who don't know, Catherine graduated from Tufts University in 2017 and has been with us as part of our, of course, internal medicine program before she became the chief. But the great news is that she's going to be staying here at VCU, and so we're very excited that she has matched into our pulmonary and critical care fellowship. So more great things to come from Catherine. And then our expert today is Dr. David Jess, who I'm just delighted to introduce. As you know, many of you know David, of course, already. He's one of our academic hospitalists and an assistant professor in our hospital medicine division. Actually has a long history on the MCV campus, been here as a medical student since 2009 and then part of our internal medicine residency program and joined faculty in 2016. So that's a real deep interest in medical education. Is an instructor in our practice of clinical medicine course, and with Dr. Garber co-directs our capstone project for our graduating fourth year medical students who are matching into our internal medicine programs. I'm really interested in clinical reason and simulation-based experiences, and I think he's probably going to share some of that expertise today. Now, something you might not know about Dr. Jess here is that before the pandemic clipped his wings, he was trying to visit every national park in the US. And so when he's completed these, I'm going to take him to Scotland so he can visit some there. But I think he'd be happy to take in the chat any suggestions you have for where he should go next. So we're just delighted to have your clinical expertise here, and thanks for sharing that little bit of fun about yourself. So we look forward to the CPC, and we'll let you take it away.
Well, thank you so much, Dr. Syme. I will start us off with a brief description of the case. So we have a 51-year-old female with a history of renal transplant, and she's presenting with fevers and pancytopenia. So the fevers started about 1 day prior to admission. They were associated with non-bloody, non-bilious vomiting, non-bloody diarrhea, malaise, myalgias, and headache. The GI symptoms started a few days prior to the fever. She's been having 6 to 8 liquid bowel movements per day, vomiting 1 to 2 times per day, without abdominal pain, no alleviating or exacerbating factors. Her husband does mention she's been mildly confused for maybe a day, just with some slower thought processing, but otherwise has been acting normally. She has no sick contacts, no recent travel or other illnesses, no recent medication changes, and has had good compliance with her current medications, although she has been vomiting for the past few days. For her review of systems, she's had fevers, generalized weakness and fatigue, nausea, vomiting, and diarrhea. She does report some decreased urination and excessive thirst, the myalgias, and headache. In regards to her past medical history, she has a history of renal failure secondary to IgA nephropathy. She underwent living unrelated donor renal transplant in 2005. She had recurrence of the IgA nephropathy and was retransplanted in 2011. She has chronic myeloid leukemia diagnosed in 2018, which has been well controlled on dasatinib therapy. She has hypertension as well. Her family history, a brother with colon cancer. She has no known drug allergies. For medication, she's on dasatinib, metoprolol, nifedipine, prednisone 5 milligrams daily, tacrolimus 4 milligrams every 12 hours. She's on biotin at an unknown frequency. She takes a multivitamin and then is on some PRN medications, which she has not been taking recently. For social history, she doesn't use tobacco, alcohol, or other drugs. She recently moved to Virginia from Georgia about 3 months ago, but has had no other recent travel. She denies any remote or recent travel outside of the United States. Her new home has town water. She works remotely as a school registrar and has been social distancing since the pandemic began. She mostly spends time around the home or goes for walks outside with her dogs. She lives with her husband and 2 dogs in Nottoway County. On physical exam, she has a temperature of 39.6, blood pressure of 144/85, heart rate of 106, respiratory rate of 21. She's standing well on room air. She's awake and alert. On eye exam, she has some conjunctival pallor. HENT exam, dry mucous membrane. She has no oral lesions or ulcerations. Her neck is supple without nuchal rigidity and no cervical lymphadenopathy. On cardiac exam, she's tachycardic, has a 2 out of 6 systolic murmur, heard best at the right upper sternal border, no peripheral edema. Pulmonary exam, she's clear to auscultation bilaterally. Abdomen is soft, non-tender, non-distended, no rebound or guarding, no appreciable hepatosplenomegaly, no CVA tenderness or Murphy's sign. She has normal active bowel signs. On neuroexam, her cranial nerves, sensation and strength are normal. She has no abnormalities on musculoskeletal exam. Her skin is without rashes, ulcerations, bruises, or petechiae, and her speech is normal with full content. For laboratory studies, on basic metabolic panel, her sodium is 132, BUN of 40, creatinine of 3.0 above a baseline of 1.6. For complete blood count, her white blood cell count is 1.6 with a neutrophilic predominance. Her hemoglobin is 9.9, platelets of 43. Her RDW is 14.6, reticulocytes is 0.6, reticulocyte count is 0.01. Her LDH is 1,194. Protein is 6.1, albumin is 3.1, AST of 262, ALT of 68, triglycerides of 224. Her fibrinogen is 163, CK is 10,047, ferritin of 7,404, tacrolimus level is less than 2. She has a negative COVID test. Her CMV and EBV DNA quants are undetectable. Her urinalysis shows protein, moderate blood, and 1 RBC. For imaging, she had a CT chest without contrast, which did not show consolidations, but did show a trace pericardial effusion. Her CT abdomen pelvis, also non-contrasted, showed mild intraluminal fluid in the colon, suspicious for diarrheal illness. She had no evidence of obstruction or significant inflammation. She has diverticulosis without diverticulitis. For hematopathology, on peripheral blood smear, she has pancytopenia without circulating blasts. Her bone marrow aspirate showed mild hypocellularity of the bone marrow with maturing trilineages hematopoiesis and increased megakaryocytes. She has histiocytic hyperplasia and macrophages demonstrating hemophagocytosis. She has no evidence of lymphoproliferative disorder, and she has no hematologic features of CML. Her flow cytometry is without leukemia or lymphoma findings. You can find the information I just described in the pamphlet attached to the Grand Rounds email. And with that, I will transition to Dr. Jessee, who is going to walk us through this case.
All right, I'm just pulling up my PowerPoint here. Kat, can you see that?
Yes.
And you can hear me
it's a
okay,
presenter view.
Oh. Okay. I'm not sure how to. How about that?
That is perfect.
Okay. Whew. Made it through my first technical challenge. It certainly won't be the last. Well, thank you, everyone. And thank you so much, Dr. Syme and Dr. Hess for such a warm introduction of me and the case information. I'm certainly looking forward to when we can be back. We can all be back in Sanger Hall together doing these in person. But I'm truly honored to be asked to present at Clinicopathologic conference. And I think we have a great case, as you've already heard about, that we can go through today. So I have just a few objectives for the session today. I think hopefully throughout and by the end of the session, we should acknowledge uncertainty as a powerful tool when approaching a clinical unknown. We should organize common problems into dependable frameworks. We should use clinical reasoning to anticipate key aspects of the history, exam, and data. And we should incorporate unexpected findings to prompt further inquiry and refine the problem representation. Finally, we should compare some known illness scripts to a narrowed differential diagnosis and to select a diagnosis from that list. I think this is the only slide I stole from someone else. You guys might remember this quote from Dr. Pat Fadden, who presented at CPC about a year or so ago. And this is a quote by a hospitalist, well-known hospitalist in California, who's Gurpreet Dhaliwal. And he says, A diagnosis is a judgment characterized by uncertainty and probabilistic reasoning. It is seldom definitive at the initial point of care. And I think Pat may have spoken to this at that time, but I get something very similar to, I think, what he got out of that, which is that there are two things here. One is that we should be humble enough to know that we may not be right at the first go around. And two, that we should be kind to ourselves and compassionate to ourselves, knowing that it's okay to be wrong. And in fact, being wrong is something we should be familiar with as internists, and that can help us re-expand our differential and get to the right answer. Additionally, we should use our clinical curiosity as a powerful tool. So our quest for certainty should not sideline our curiosity. We shouldn't ever be comfortable being too certain. And in fact, being too certain, never being in doubt, paradoxically results in lower quality care through over-testing, premature conclusions, and tunnel vision. That's from Ronald Epstein. So let's define a couple things before we begin. What is a problem representation? Many of you guys are familiar with this, but it's a fluid, concise summary statement that highlights the defining features of a case, which helps us generate a focused differential diagnosis and inform the next steps in diagnosis and treatment. More simply, this is the who, when, and what of our patient. The who being the patient themselves, the when being the time course and the tempo of their disease, and the what being the actual clinical syndrome. What is an illness script? An illness script is kind of the opposite side of the coin. It's an organized mental representation of a disease's story or presentation. To give us some examples, you guys are all familiar with illness scripts. This is like orthopnea, P&D, an elevated JVD, and a positive S3. You see that and you automatically think of heart failure, immobility, dyspnea, chest pain, unilateral leg edema. You see that, and immediately my mind goes to pulmonary embolism. They can also be a little more challenging and a little more detailed. Scandinavian woman, episodic abdominal pain, depression, history of seizures, dark urine. That might be a problem representation for acute intermittent porphyria. Finally, you may hear me refer to the bucket. I think people have different terms they use for this. I sometimes use the bucket. The bucket is where we're going to throw some pieces of information that we don't necessarily know what to do with as we go through the case. The bucket is not a trash can. So the bucket is not a place where we throw things away. It's just where we keep some things that we might need to bring back later. Sometimes people refer to this as the back burner or something else like that. So we start with our chief complaint. We have a chief complaint of fever. So when we think about a fever, we can use a certain framework to help us develop a differential diagnosis for the fever. And one of the frameworks I like the best is something called IMADE. Now, why do we use frameworks? Frameworks help remove some of the cognitive load from coming up with a diagnosis, meaning there's a lot of things on our mind. And so if we can take some of that cognitive load off and immediately help us think about some differentials. So some common causes of fever is infection or inflammatory issues, malignancy, autoimmune disorders, drugs and toxins, and endocrine disorders. Furthermore, we can further clarify this framework by also applying a time course, being acute, subacute, or chronic. When we apply known differentials to this framework, you can see that we have an expanded differential pretty quickly of all these different things that can fall into the IMADE framework, all these common conditions, common or uncommon conditions that can cause fevers. When we apply the time course, we realize that we can even from just knowing the chief complaint and just knowing a little bit about the time, we can start to narrow the differential very quickly. Getting rid of, in most cases, malignancy, autoimmune disorders, and even endocrine disorders, which helps us narrow the differential very quickly. But if I'm being honest, when I hear about this case and I hear some of the history, one of the first things that comes to my mind is infection. And so that's where I am probably going to be gravitating towards a little bit as we get some more information. So Kat already presented the history of present illness, and so I don't want to repeat all this to save some time. But essentially, the history of present illness tells us the what. Remember the who, the when, and the what. This is the what of our clinical syndrome. So this is information that she already presented and that you have in the case packet, highlighting here just a couple of the more pertinent pieces of the what. The time course being 1 day, and the no abdominal pain. I thought that that was very interesting, and I'll come back to that as we go through the case. Certainly, we can use other frameworks. Another framework that I actually used to initially approach this case was a diarrhea framework. I know it's your lunch hour, so I promise not to spend too much time talking about diarrhea, but we can break this into inflammatory causes, osmotic causes, secretory causes, or dysmotility. But as I began to work through this framework, certainly there's a lot of differentials that fit onto this framework, but many of these differentials just don't apply to the history that we have. There are some things on this differential, though, that I want to keep in mind, like C. diff, Listeria, Cryptosporidium and Isosporidium, and cytomegalovirus. These are things that are more common in patients who have underlying immunodeficiency or on immunosuppressants. And so I think this question really came up when I was deciding between the fever and the diarrhea. What is primary and what is secondary? If we think about this, certainly the diarrhea could be the primary issue. We could have an underlying disorder that's causing diarrhea and then fevers and malaise, myalgias, and headache, or the diarrhea could be part of the clinical syndrome itself, meaning that there's another process that we have yet to discover that's actually causing fevers, diarrhea, and systemic symptoms. And this is the what. This is our syndrome. Going back, thinking about that we had already talked about that infection was more likely, we all know that there's different infections that could account for this clinical syndrome. The patient gave us some of her review of systems, which suggested that pneumonia was unlikely, a urinary tract infection was unlikely, skin and soft tissue infection unlikely, biliary issues being biliary and GI issues being unlikely, and CNS meningitis. I think probably unlikely in this case, though would need to get a little bit more history before I completely ruled out meningitis. And then the fact that she's not having rigors suggests that she's probably not having a bacteremia. Of course, there's other things, other infections like viral, fungal, and atypical things that can cause systemic symptoms or even local focal symptoms too, and occult infections. So I'm going to keep the meningitis piece in the bucket, come back to that maybe later, but the rest of this helps us clarify our differential. The medical and surgical history is the WHO. Highlighting here her history of IgA, kidney transplant, on immunosuppressants, and on dasatinib with a history of CML. These medications that she's on, certainly something to keep in mind. We know she's about the immunosuppressants, we know about the tyrosine kinase inhibitor, and the antihypertensives, not necessarily something I want to throw away, but something that I'm probably going to keep in the bucket for later. The WHO is further defined by her family and social history, the history of colon cancer, the fact that she just moved from Georgia to Virginia, but that she hasn't traveled anywhere is certainly important, that she has 2 dogs and she goes on some walks, and that she drinks town water. In the history, we heard about Nottoway County, and for those of you who aren't as familiar with Virginia geography, this is only one of 2 geography lessons I will give during this presentation, I promise. Nottoway County is highlighted there in pink. She came from Georgia to Nottoway, and right there, circled in blue, you guys can see that, is Richmond, so not too far away. So what is a problem representation? We already talked about this, the who, the when, and the what. So we can certainly start with a very descriptive problem representation. A 51-year-old woman with CML on dasatinib and a history of IgA nephropathy requiring renal transplant ×2 on tacrolimus and prednisone, presenting with a few days of watery, non-bloody diarrhea and vomiting with abdominal pain, as well as 1 day of fevers, malaise, myalgias, and headache without clear localizing source. Whew, that was a lot to get through, right? But we can refine this by using semantic qualifiers, different phrases which can group some of these things together. So a 51-year-old woman on immunosuppression presents with acute onset of fevers, nausea, vomiting, watery diarrhea without abdominal pain, and systemic symptoms without clear localizing source. But I'm still not happy with the green, the syndrome. And I think we can further tailor down that green section by defining what is this? Fevers with nausea, vomiting, and watery diarrhea, all of this. We oftentimes refer to this as simply a flu-like illness. So next we move into the vital signs. At first glance at these vital signs, The one thing that really sticks out, of course, is the fever. A temperature of 103.3 is certainly warm, certainly hot, a very high temperature. You might be quick to move through these and move on, but if we really attend to the vital signs, we might notice that there might be something to pick out of this. A really high fever with a heart rate of only 106 and a patient who's been having really watery diarrhea, that doesn't really compute with me. And in fact, is there something there that's not right? This actually is Liebermeister's rule. This refers to Liebermeister's rule. When in febrile illness, for every 1 degree increase in temperature, centigrade, there should be about an 8 beats per minute increase in the temperature, in the heart rate. Faget sign is, or more difficult to say, sphygmothermic dissociation or temperature to pulse dissociation is a violation of that rule, resulting in relative bradycardia. When is this seen? When is this commonly an issue is with either leptospirosis or other intracellular organisms like bacteria and viruses and parasites. But we have to pull something out of the bucket, right? And to pull out of the bucket, we have to pull the metoprolol out. So the metoprolol completely throws apart this whole situation here, because I don't know if this patient has Faget sign or not now. Now, the metoprolol could certainly be lowering her heart rate. The physical exam. So down at the bottom here, I just highlighted the abdominal exam simply because that was where I really wanted to do a really thorough exam, but of course being thorough throughout, and we don't have a focal source of infection. Furthermore, we can highlight here what are the either unexpectedly normal or abnormal things in the physical exam, being her murmur. We're not told much about this. So, is it a crescendo decrescendo murmur like we might hear in aortic stenosis? Or is it simply just a referred murmur from her old fistula or graft? And I'm making an assumption here that she might have an old fistula or graft because she has had renal failure ×2, right? And then the conjunctival pallor is certainly interesting. Don't know what to make of that yet. Don't know what to make of that yet. And then thinking about the very first thing on the physical exam, which is her no acute distress. When you plug that in with her temperature, that certainly is interesting, right? When is the last time that you ever had a patient who was this febrile, who was in no acute distress, who wasn't diaphoretic, who wasn't sitting there looking unwell? I think that this is certainly part of our syndrome, and we should plug that into the problem representation. In this case, saying that this patient has a non-toxic, non-focal exam. Next, we move into the labs. And I think the labs, the way I approach laboratory information is thinking about expectations versus reality. I'm not going to get, even if things are abnormal, I'm not going to get too worried about them if it's something I expect. But if I see something that's unexpected, well, that's certainly something I should pay more attention to, right? So what do we anticipate? Before looking at the labs here, I anticipated that this patient was going to have an AKI, an azotemia, and acidosis, and electrolyte abnormalities. I expected a normal lipase just because she's not having any abdominal pain. I expected an elevated specific gravity in her UA and a leukocytosis, as well as hemoconcentration. But we think about that piece of the physical exam that suggested she had conjunctival pallor. And so maybe we actually should expect anemia instead of hemoconcentration. What do we actually see on the labs? Well, our suspicions were correct. We predicted the abnormalities and the metabolic panel and the electrolytes. She has a normal lactate, not going to, a little unexpected, but not necessarily know what to do with that. I think I was even more surprised by her normal urine specific gravity, which suggests that she has an estimated urine osms of less than 300, which suggests she's making pretty dilute urine. That doesn't really compute with the clinical situation we have, but these are unexpected, and we'll put the specific gravity in the bucket and move on. And then thinking about more expected results, being her bilirubins, alk phos, lipase, we already talked about, but then some unexpected results, right? This AST that's significantly higher than the ALT, well, that prompts some things that come to mind right away. Alcohol abuse, rhabdomyolysis or muscle damage, and myocardial injury. Well, we know her troponin was only 0.01, and so we don't think that there's any myocardial injury here. But then we check a CK to see if there's any muscle damage. And whoa, we see a CK of 10,047. That is certainly a surprise, I think, even with the AST being up. Taking that CK and using some of the other information we have, we see the urinalysis, which has moderate blood, but only one RBC, which suggests that there's a myoglobinuria. And of course, the AST being higher than the ALT. Without having any specific muscle pain, indicating a myositis, which she does not have, and just having myalgia and this other flu-like syndrome, this is certainly rhabdomyolysis. We go back to the question of what's primary and secondary, and I believe rhabdomyolysis, as it often is a secondary process in this syndrome. And we take that and we plug it in to the problem representation. Laboratory data. What do we expect? What is reality? Well, her baseline CPC we're told is normal, but unexpected based on her history, but expected based on her exam. We have an acute anemia here, hemoglobin of 9.9 and a low hematocrit. What else do we see? A white count of 1.6 and platelets of 43. These are certainly surprising results, especially for a patient who previously had a normal CBC. We flesh out the CBC and we see that all of her cell lines are down. And when we see all the cell lines being down with leukopenia, anemia, and thrombocytopenia, we call that pancytopenia. We have some other labs here which might help us further clarify what type of pancytopenia this is, or if there's any other abnormalities we should be considering, any other conditions we should be considering. And we see here that her LDH is high, actually quite high, and we'll throw that into the bucket. But her haptoglobin isn't low enough that we would expect hemolysis, and she has no schistocytes on her smear, also suggesting that she probably doesn't have a hemolytic issue going on. Now, we can use the pancytopenia framework to help us further clarify what might be going on with this patient. But to save us some time, I'm just going to highlight some things here, which I immediately gravitate towards, because the pancytopenia is not our primary framework. The IMA, the fever framework, is our primary framework. We look back and we saw that we already defined pancytopenia, and we plug that in. We decide if it says, is that primary or secondary? And we think this is secondary, or I think this is secondary. And we plug that into the problem representation. Finally, we see some other labs that we might get to help us further clarify her anemia. And we see something that is very interesting, which is the ferritin of over 7,000. Now, if you got many of you out there probably already start to think about some things that cause a really high ferritin, hyperferritinemia. This was a big surprise for me, something that was unexpected. We have some other labs that can help us clarify what the cause of the hyperferritinemia is, but probably the most helpful thing is her bone marrow biopsy, revealing that she has hemophagocytosis and histiocytic hyperplasia. What does that look like on the bone marrow biopsy? Well, here we see an activated macrophage, which is the big cell in the middle there, which is consuming both an erythroid precursor here and a mature erythrocyte here. That's hemophagocytosis. We can use our hyperferritinemia framework to further clarify what the causes of hyperferritinemia are. But to quickly go through this, I think the point of this slide is to basically say that an iron overload issue as her cause of hyperferritinemia is not going on. Her transferrin sat is only 25%, and so we can completely eliminate this side of the framework. And here, we already see some things that we've already found on other parts of the history and the labs, being the hemophagocytosis, and we have a suspicion for infection too. Finally, the imaging data. And point being on this imaging is that sure, there's some gallbladder wall thickening, but generally, I'm gonna just to summarize all of this imaging as saying there's an absence of significant findings on the imaging here. Again, it does not really help us point towards a focal source of infection or a focal process. Just briefly, because it wouldn't be a CPC without talking about hemophagocytosis. What is hemophagocytic lymphohistiocytosis? Well, this is a busy slide, but it's an immune-mediated hyperactivation of cytotoxic T cells and impaired natural killer cell function. Often can be idiopathic, but in adults is usually triggered by something else and can be very common in transplant patients, or at least more common in transplant patients. And the illness script for pancytopenia, for phagocytosis, HLH, is fever, hepatosplenomegaly, hyperferritinemia, cytopenias, and activated macrophages in like the bone marrow or the spleen. This slide essentially just summarizes the likely causes of HLH. In the green box, we see genetic susceptibility, much more pertinent in pediatric patients. In the purple, we see some acquired susceptibility. And then in the red box or pink box there, we see all the potential triggers for HLH. Finally, when we further define triggers of HLH, obviously there are lots of infections here that can cause HLH. But certainly, being a transplant patient also increases your risk of HLH. Additionally, we can break HLH down into its common causes, and we see that there are some infections which seem to be more likely cause HLH. For example, here we see that Epstein-Barr virus causes somewhere between a third to half of all viral-mediated HLH, whereas histoplasmosis causes over half of all fungal-mediated HLH. Here's all the potential diagnostic features of HLH. But we also have this great guideline, this diagnostic guideline from the Histiocytosis Society, that is a society apparently, that they defined in 2004, which of course you can have here the genetic predispositions to HLH, but more often, there's the elevated LDH. I apologize that I had to pull out of the bucket. Sorry about that. In looking at our guidelines here, we can see that the patient has to meet 5 of these criteria to be considered for HLH. And I would argue that our patient definitely meets 4 of these and probably is on the cusp of meeting a 5th or 6th. The fever, the cytopenias, the hyperferritinemia, and the hemophagocytosis on the bone marrow. She also has some mild hypertriglyceridemia and some mild hypofibrinogenemia. And then interestingly enough, if you go on MedCalc, you can find the H-score. Now, the H-score is a validated tool where if you consider that your patient could have HLH, you can plug in a lot of different factors. For example, other things that aren't on this list like immunosuppression, and calculate an H-score yourself. There are some drawbacks to this test, and I won't go into those right now, but essentially it's an additional tool in your tool belt. And our patient had a calculated H-score of greater than 99% of hemophagocytosis syndrome. So this patient, I'm going to make a diagnostic decision and say she has hemophagocytosis. And we finally plug that into our problem representation, and we get our final problem representation. A 51-year-old woman on immunosuppression presents with acute onset of fevers and flu-like illness with a non-toxic, non-focal exam and evidence of rhabdomyolysis, pancytopenia, and hemophagocytosis. Einstein said, if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about solutions. And that's really what we've done here, right? We spent a lot of our time just thinking about the problem, which is the problem representation. We have to think about what is the right question to ask. It's like kind of like Jeopardy, right? We have to ask the right question. And a good problem representation then informs our differential diagnosis. But our differential diagnosis should not work backwards and inform our problem representation. Finally, we get to the differential diagnosis. And we've already ruled out a lot of these things for various issues that various reasons I won't go into. But for example, the TTP, not seeing schistocytes on the smear, the sarcoidosis, no imaging of that, no signs of leukemia on the bone marrow. And I'm just going to mark some of the rest of these off that we've already talked about to save some time. One of these that I do want to mention is just the adult onset Still's disease. Certainly a known cause of fever and hyperferritinemia, but our patient has no arthralgias or rash or other pathognomonic things that go along with adult onset Still's disease, and so we take that off as well. The final big category here that we haven't talked about besides the infections, and excuse me, we've already defined that this patient we think has HLH or at least a hemophagocytotic syndrome. The final thing we haven't talked about here is the drugs or toxins. And so just briefly, I'm just going to say that tacrolimus and dasatinib certainly can impact the metabolism of each other. Tacrolimus can affect the P glycoprotein and thus cause higher levels of dasatinib. And dasatinib can impact the CYP3A4 metabolism and cause higher levels of dasatinib and cause higher levels of tacrolimus. Therefore, we'll take those off the differential as well, and focus solely on the infections. And the infections I've broken into diarrheal infections and systemic infections. As you guys can see, I had a hard time at first coming off of the diarrheal infections because the GI symptoms were so profound, and that's why I left them on this slide. When we think about common causes of diarrheal infections, bacterial, viral, and parasitic, and then systemic infections, or infections that cause systemic symptoms, bacterial, atypical, tick-borne, zoonotic, viral, parasitic, etc. I'm going to mention one thing about CMV on the next slide, and so I'm going to put that in the bucket and move on. But I am making a prediction here, and that I suspect that some or all of these tests highlighted in purple here were sent by the team who did the initial workup. And I'm going to predict that the C. diff was negative, that the stool ovum parasites were negative, and that the stool multiplex PCR were all negative. And I say that because, again, remember on the imaging, we had no colitis and the patient has no abdominal pain. I would expect some imaging abnormalities and abdominal pain with all of these diarrheal infections. Finally, we move into systemic infections, and we can start to mark some of these off with the data we already have, being the COVID being negative, the EBV and CMV being negative. And the bucket that I put there is simply to mention that there is a teaching point here, and that if you think you could have CMV colitis, then a DMV CNA quant is not enough to rule out CMV colitis. But I felt that we had enough information to rule out CMV colitis simply based on the exam and the imaging and the history. And so the CMV DNA quant here being undetectable Sorry, I think my video just went out here. Give me 1 second. Do you see me?
We can see and hear you. Yeah.
All right, sorry about that. And sorry, the fungitel being undetectably low rules out histoplasmosis, and a blood culture being negative takes out the systemic GPCs and GNRs, and the fungal culture being negative rules out Candida. So now we have a narrowed differential diagnosis. And I'm going to admit one thing, which is that this morning, I realized an entire category that I forgot to put on this slide. And so I just simply added it in just now, which are mosquito-borne viruses. I don't have any slides to talk about these right now, but I think you guys can trust me on the fact that this patient has not had any travel to endemic areas to suggest dengue or chikungunya or Zika. These are possible in the United States, in like the very southern United States, like Florida and Texas. But I think it's unlikely in this patient's case. And then West Nile virus, certainly throughout the United States is possible, but generally we think of a viral syndrome, a flu-like illness with arthralgias and an encephalitis, which this patient does not have. Finally, we're narrowed to a much more compact differential here, which I've now expanded to include many of the possible specific diagnoses within these categories. We finally start to apply a known illness, we finally get to start applying known illness scripts to a narrow differential so that we can begin to pick a diagnosis. Briefly about the parasitic infections. Well, malaria certainly would be an interesting diagnosis here, but this patient does not have any of the classic typical clinical symptoms and hasn't had any travel to these endemic areas. Same thing for leishmaniasis. Strongyloides could occur in the southern US, but she's not an agricultural worker. She doesn't walk on bare feet. And so I think that that's unlikely. And then toxoplasmosis is probably the most likely of the parasitic infections, but she doesn't have any history that suggests a foodborne or foodborne, that she acquired this via a foodborne way. And she doesn't have any tender lymphadenopathy. So we'll take the parasitic infections off and move into the atypical infections. Now, the atypical infections certainly have very classic syndromes, classic illness scripts, right? For example, nocardiosis. The things that come to mind when I think of nocardiosis are an underlying immune deficiency, lung nodules, and CNS infection, which this patient does not have. And of course, tuberculosis, for example, is a illness script that we learn early in medical school, probably during my first year, thinking about the weight loss, night sweats, hemoptysis, and the cavitary lung lesion. Of all of these, I think Legionella is the most likely. Legionella can cause diarrhea, hyponatremia, which we saw, and can cause a positive Faget sign. It is well known to cause that. But this patient has been at home. She's been social distancing. She hasn't been traveling anywhere, and she definitely hasn't been on a cruise ship or gone to a hotel conference. And so I think that that's unlikely. And I think the biggest thing to pull out of this is that usually these syndromes, when they're causing systemic illness, also cause pulmonary symptoms, which this patient did not have. No pulmonary symptoms, no respiratory symptoms, and no imaging findings of these. So we'll take the atypicals off and move into the zoonotic infections. Now, I had a patient with leptospirosis here 3 years ago. A gentleman who had been digging in the soil as part of his line of work. He came in with flu-like symptoms and rhabdo. That could be, could cause, that's a illness script for lepto, but doesn't line up with our patient's problem representation, right? And then you have really interesting things on these zoonotic infections, like brucellosis, an exposure to unpasteurized or raw dairy with undulating wave-like fevers and a sweat that smells like moldy hay. I didn't even know that, but apparently that's a thing. But you'll take my word for it that this patient does not have any of the illness, that these illness scripts do not align with the problem representation we have for this patient. Finally, we move into the rickettsial diseases or the tick-borne illnesses. And sometimes, sorry, I kind of did this a little fast, but sometimes we have a humorous way that we refer to the tick-borne illnesses, and that could be even more simply defined as a doxycycline deficient state. And I think the point of this is that, especially as we approach the spring and summer, if you see a patient who comes in with a flu-like illness, rhabdo, and some other non-focal symptoms, a rickettsial disease should be in our differential diagnosis. And it's reasonable, especially if the patient's getting worse, to not withhold doxycycline. We should be not hesitant to give this medication. What are some tick-borne infections that we're familiar with? We're obviously very familiar with Lyme disease or Borreliosis, but this patient doesn't have a problem representation that fits with Borreliosis. She has the flu-like illness, but no migratory arthritis and no cardiac issues. She does maybe have a little mild encephalitis, but definitely does not have this erythema migrans rash, right? And then tularemia. As far as we know, this patient hasn't been around any sick rabbits, and she doesn't have this focal lymphadenopathy, which we see here. So those are not, I think those are less likely. Finally, we move into this middle group here. And I promised only 2 geography lessons, and this is the second geography lesson. So the CDC has information about generally what are the endemic areas for these rickettsial diseases, these tick-borne illnesses like anaplasma, babesia, Erlichia, and Rocky Mountain spotted fever. So let's talk about Rocky Mountain spotted fever first. Rocky Mountain spotted fever, despite its name, is actually seen in all of the contiguous 48 states. It even has been known to be found in the Bronx, in a city park in the Bronx in New York City. It does cause a flu-like illness, but our patient did not have any rash. And while you don't have to have a rash with Rocky Mountain spotted fever, it certainly is more common to have a petechial rash. Babesiosis. Now, babesiosis is interesting and probably one we should separate just a little bit from the rest of them for 2 reasons. One is that whereas these other rickettsial infections actually invade lymphocytes or leukocytes, babesiosis infects red blood cells. And it actually causes a malaria-like syndrome because it infects red blood cells. Because it infects red blood cells and can have a syndrome similar to malaria, it can cause jaundice and multi-organ failure. And we have a pathognomonic thing that we think about with babesiosis, which is the Maltese cross, which you can see here, seen on the smear, but our patient did not have on her smear. Finally, one additional thing I just want to mention about babesia is that even though it's grouped into the doxycycline deficient states, babesia is generally not susceptible to doxycycline. And so if you have a suspicion for babesia, we should think about other antibiotics like clindamycin as a first choice. Finally, we move into anaplasmosis and Erlichiosis. The problem with these two is that they overlap a lot. And it's very hard to differentiate these two syndromes from each other. So here on the left, we're going to talk about how they overlap and what looks similar between the two. Is that obviously very similar syndromes. They can cause a flu-like illness. They both generally are less likely to cause a rash than like Rocky Mountain spotted fever. And they are well known to be associated with rhabdomyolysis, cytopenias, and reactive hemophagocytosis. And certainly all of these infections, especially because they're intracellular, remember we talked about intracellular stuff earlier, because they're intracellular, can have increased risks with patients who are on immunosuppression. Then we get to the really tough thing of trying to decide how do we differentiate the two from each other. And I'll admit, this was really challenging looking through the literature and trying to find the subtle things that separate these two illnesses. Anaplasmosis usually does not have a rash, though interestingly, a lot of patients who get anaplasmosis are bitten by a tick who also is infected with borreliosis. And so you can see erythema migrans in anaplasmosis because that patient also got Lyme disease at the same time. Anaplasmosis invades neutrophils. And for Erlichiosis, you can see a rash that's generally more common than an anaplasmosis, but again, much less common than you would see in Rocky Mountain spotted fever. And I think what helps separate this out is that the GI symptoms in Erlichiosis are generally more profound. The final thing that separates the two is that you see this word morulae. So what are morulae? Morulae are these intracytoplasmic inclusion bodies. Sorry, I'm a little behind on my clicking here. Intracytoplasmic inclusion bodies, which can be seen on a smear. The problem in Erlichiosis is that it's difficult to see morulae on a smear, but in anaplasmosis, morulae are seen more often. And in fact, here we see what a smear in a patient with anaplasmosis might look like, which is described as a mulberry-like group of intracytoplasmic inclusions, which are inside this neutrophil here. And there's where it is. So we've talked about all of these differentials. We talked about that Rocky Mountain spotted fever and Babesia were unlikely, and we get to having to make a final decision between these two. And based on these patients' clinical syndrome, her history, her exam, her labs, her smear, and other information, I'm going to make a diagnostic decision that we're dealing with Erlichia. How would we get a pathologic or a serologic diagnosis for Erlichia? Well, in our electronic medical record, we would type in Erlichia, and that would come up as Erlichia HME or HGE, IgM, and IgG, but we could also send a PCR. You might be asking yourself, what is HME and HGE? There are two kinds of Erlichia, which are common in humans. The most Erlichia schaeffiensis is the more classic, common type of Erlichia, and that's human monocytic Erlichiosis. And then there's less well-defined human granulocytic Erlichiosis. So we finally have made a diagnostic decision here. We have selected a diagnosis, and we plug that into our final problem representation. A 51-year-old woman on immunosuppression presents with acute onset of fevers, flu-like illness, with a non-toxic, non-focal exam and evidence of rhabdomyolysis, pancytopenia, and hemophagocytosis, which I think is due to human monocytic Erlichiosis. And I just want to acknowledge everyone who in big and small ways helped me as consultants and helped me prepare for this case today. And that's all I have.
Well, that was just fantastic, Dr. Jessee. Thank you so much. I will move on to our expert for this case, Dr. Alexandra Bryson, who's an assistant professor of pathology here and the associate director of clinical microbiology at VCU.
Hi, thank you very much for having me here today. Can you see my slides all right?
Yes.
Yes.
Great. Thank you, Dr. Jessee, for that phenomenal presentation. So we'll go ahead and dive into our laboratory results here. so starting off, you'd already covered this. We've got transplant patients we want to consider CMV. Patient had a positive IgG and an equivocal IgM, and that quant was undetectable. And if this patient really had CMV as their true cause, the patient should have been viremic if they're at the stage where they were leukopenic, thrombocytopenic, and had elevated LFTs. There are rare exceptions where patients with CMV colitis might have an undetectable DNA, but for this case, this was not the case, so we can rule out CMV. EBV, this patient actually had a series of EBV tests throughout their chart, most of which were negative. They did have a low quantitative viral load at one point, which ID had really said that they think this is just a reactivation from past exposure. So we've got our positive IgG response. This patient is presenting acutely. So the fact that we've got these antibody positive results already really doesn't match up with the fact that we've got an acute presentation. So we'll go ahead and rule out EBV. We did order a Leptospirosis IgM, and that was negative. And here's what comes to mind for me is we've got a patient who has a fever, thrombocytopenia, leukopenia, and elevated liver enzymes. And I don't think Dr. Jessee had this info, but this is in May, and that's tick season. So we think about our tick-borne illnesses. So the three most common ticks that we have here in Virginia are our Ixodes scapularis, our Amblyoma americanum, and our Dermacentor variabilis. So for time, I'm really just gonna kind of focus on what is most common here in Virginia, and that is our Amblyoma americanum. And that tick can transmit Erlichia chapiensis, Erlichia owingii, Heartland virus, and Francisella tularensis. So three of those were on the earlier differential. Just to also point out for Anaplasma and Babesia, our Ixodes scapularis is our tick vector. There's a relatively newly discovered species of Erlichia, Erlichia muris oclarensis, which is transmitted by the Ixodes tick, but that's really just in the Midwest. And again, here's Babesia as well for that differential that you've listed. Rocky Mountain spotted fever, our Dermacentor variabilis. These are just images of what each of our ticks look like. Okay, so we'll get to the tick-borne illness diagnostics. So they had ordered Anaplasma serology, IgM and IgG, which was negative, and PCR testing. So PCR for Anaplasma was negative, and PCR for Erlichia chapiensis was positive. So excellent job. This is human monocytic Erlichiosis. And Erlichiosis, again, it consists of these three different species. We really don't know much about this latest Muris oclarensis. The ones we think of are chapiensis and owingii. This patient was given doxycycline 100 milligrams 2 times a day. They were supposed to take it for a week, but they took it for 5 days while they're in the hospital and then stopped taking it the last 2, according to the notes. So Erlichiosis, we've already covered most of what's in our case presentation here, but just to highlight on the left here, these are the abnormalities that we see in both Erlichiosis and anaplasmosis, and everything in a red check here was present in our patient. And you can see the median percentage of patients who present with this finding. So we've got our fever at 96%, headache at 72%, the myalgias, malaise in the 70s, vomiting, diarrhea, which was one of the big clues for this case, a little bit of confusion, mental status changes, leukopenia, thrombocytopenia, anemia. So we had that in our patient, and then those elevated AST and ALT levels. Rash, typically not seen in adults. It's more common in children, and it's less than 1 in 3 people who actually present with a rash. The rash itself is more common if you've got the Erlichia chapiensis species opposed to Erlichia owingii. All right, late disease. Just to point out, patients can get HLH. It's very rare, but this is possible. And so that fits with our patient presentation that we saw. and discussed earlier. Mortality can be up to 3%. And then risk factors for patients, very young, very old, people with a weakened immune system, and if patients get delayed antibiotic treatment. Most people, however, actually recover just fine without treatment. So here are the morulae. I just wanted to highlight the differences between them. So Chaffiensis infects monocytes most commonly, Erlichia, granulocytes, and I put anaplasma on here. That one infects our granulocytes, and it hasn't been defined for Ursus occlurensis. Morulae are observed in less than 7% of cases, so not our go-to diagnostic. PCR is going to be the most sensitive diagnostic within the first week. Sensitivity decreases as soon as you give antibiotics, so that sensitivity is going to go down in 24 to 48 hours. A negative result doesn't rule out your diagnosis, and the PCRs detect all the species. Serology is particularly helpful for patients 7 days post-symptom onset. To make a diagnosis, you have to collect acute and convalescent serum and look for a 4-fold antibody titer increase. And that's because patients who've been exposed in the past can have antibodies that are positive for months to a year. About 50% of patients can have an IgG antibody that's still positive 3 years post their infection. And we do see some cross-reactivity on occasion with anaplasma. So a lot of times people do serology to both Erlichia and anaplasma when they're making the diagnosis. I'm just going to fast walk through how antibody testing works. Up on the right here are these little slides that fit on a microscope. And each circle contains macrophage cells that have been infected with Erlichia chaffiensis. We've got our positive patient on the top here and our negative patient on the bottom. You add the patient's serum. If they have antibodies to Erlichia shown in purple, they bind, and we wash away the rest of the antibodies. Now we add a fluorescent tag, and this is an antibody that binds the conserved region of antibodies. So we go through a wash step and look at the results under a microscope. So if you had antibodies to Erlichia, you form this complex, bind our fluorescent signal, and you get this bright green image here, whereas our negative result is just a red negative background. I've got, I think, 3 slides on epidemiology, so we'll be fast. Cases are increasing over time. Distribution of when we see cases onset. So our patient was in May, and that's when we start to see cases start to peak up. June and July, all consistent with tick season and people being outside. Distribution. This is reported cases per 1 million in population, and Virginia is up here in one of the highest prevalent states. Last slide, which is our local tick surveillance. So this was a study from 2012. The city of Richmond surveys ticks, and they perform PCR on them to look for Erlichia and anaplasma. So you can see in Richmond City, they tested 40 ticks, 5% of them had Erlichia chaffiensis, and 7.5% had Erlichia ewingii. And just to give you an idea of what we see here in our patient population, between 2015 and 2021, we had 71 patients who were tested for both Erlichia and anaplasma by PCR, and we had 8 positives. We had 4 serology positive for anaplasma also over the same time frame there. And with that, we can move to questions. I know we're right at time here.
Give people a couple of minutes to ask their questions, but what a terrific job you did. Really thorough, really thoughtful, truly enjoyed it. Congratulations.
Thank you.
All right, well, if people have questions for any of the presenters, I'm sure they can email them, but I think because it's the top of the hour, we'll let everybody off the hook and back to their afternoon. But thanks to everybody, and thanks to our colleagues in the laboratory of medicine too. That was really helpful too. Appreciate it. Great job.
Thank you. Thank you, everyone.
Thank you.